Good afternoon, and thank you for joining our web seminar, Improving Procedural Awareness Using ScopeGuide. We're coming to you live, and this afternoon we will talk about as well as take questions on ScopeGuide. ScopeGuide provides a real-time 3D view of the position and configuration of the colonoscope inside the colon, allowing physicians to recognize when the scope is looping, along with having the ability to better determine anatomical locations within the colon. This provides serious benefits to both GI fellows and established physicians. This afternoon, we're in for a real treat. Our guest speaker is a gastroenterologist in Darby, Pennsylvania, with over 23 years of experience. After graduating from Philadelphia College of Osteopathic Medicine in 1990, he completed a fellowship at Mercy Catholic Medical Center. He stayed within the Mercy Health System, where he touts the benefits of colonoscopy using ScopeGuide, both to his patients and even by appearing on the local news. His patients describe him as a good communicator, noting his ability to convey complex ideas to the lay person. And most recently, he was named one of Philadelphia Magazine's top doctors. Allow me to extend a very warm welcome to Dr. Stephen Lichtenstein.
Thank you. Hi.
Joining us from the Olympus NBI team is Product Manager Stephen Hartman.
Hello.
And my name is Amanda Brimmer. I will be your host for this event. Now, please allow me to pass the presentation to Dr. Lichtenstein.
Thank you, Amanda.
No problem.
Thank you, everyone, for joining in on this live webinar. And the webinar titled Improving Procedural Awareness Utilizing ScopeGuide. This is actually where we're broadcasting from live. This is my hospital, Mercy Fitzgerald Hospital, in Darby, Pennsylvania, just outside Philadelphia. The agenda for today: what is ScopeGuide? We'll discuss how to use it, when to use it, why to use it, adverse effects of ScopeGuide, if any, benefits of the ScopeGuide, and then we'll end with a summary. So what is ScopeGuide? You see here, this is a fluoroscopic x-ray of the configuration of a colonoscope during a colonoscopy. And you can see what we're showing here is the looping, the multiple looping in the sigmoid colon. We all know this by the tension and the feel and the resistance when we're trying to advance our colonoscope through the sigmoid colon. But with this image, you would need fluoroscopy and radiation. Well, keep this image in mind, and what ScopeGuide does, ScopeGuide gives you a very typical image like this without the radiation. And you have this full-time along your entire colonoscopy procedure. Colonoscope location. Anatomically, I'm going to ask you all a question. Where is the tip of the colonoscope in the diagram to the right? How would you answer that question? Where is the tip of the colonoscope? The answer, you would say, is it's in the distal transverse colon, just proximal to the splenic flexure. And I think that's fairly easy. I think everybody would agree. And I think it's easy because you see, anatomically, you see an image of the colonoscope, and you see the colon. So you could see here, here's your splenic flexure, and you are just proximal to it. Very easy. Now imagine if you had an image like this all the time during your colonoscopy procedure. I mean, to me, that's just unparalleled. Well, let's go on to this next picture. So here you are doing a colonoscopy, and you see this ulcerated area, and you're going to take biopsies. You think it's an ulcerated area. You suspect it's ischemic, and you're taking biopsies, and your endoscopy nurse says, as they do routinely, where are the biopsies from, doctor? How would you answer that question? What is your answer when she says, where are the biopsies from? And that's your image to the right. Do you look down at your scope and say, it's at 42 centimeters? Or do you give your best educated guess and say, it's probably the descending colon or probably the transverse colon? I mean, I think it's variable. Everybody has their own way of answering that question. But this is something that we get every day, multiple times. Where are you at, doctor? How do you know? Well, when I perform the colonoscopies, and again, I've been performing colonoscopies for 24 years, my answer would be, if you look at the image to the right, and you see, if I have to take a biopsy where I'm pointing my cursor, I can answer that question with 100% accuracy where my biopsies come from. You see my ScopeGuide image here. This is what I'm looking at. And the ScopeGuide image shows, and follow along, I'm coming up the left sigmoid colon, the descending colon. Right here, I'm traversing the splenic flexure, and I just entered into the transverse colon. So I am right now in the distal transverse colon, just proximal to the splenic flexure. And I know that with 100% certainty because there's my 3D ScopeGuide image. So when I answer the question, where are your biopsies from, doctor, I say to my nurse, I am in the distal transverse colon. I very rarely look at the scope number and give a number. I think that's practically useless for most cases. And for obvious reasons, with looping, the stretch of the colon, you really don't know where you're at when you look at those numbers. With ScopeGuide, you know 100% of the time location where you're at. This information is invaluable. So that's how I would answer that question, with 100% accuracy. Not probably. I know where I'm at. So again, this is what most endoscopists see in this picture here. When I perform a procedure, this is what I see. I see, not only do I see that, but I see, in addition to endoscopic picture, I see my ScopeGuide image in addition to it. Well, why would anybody not want to have this extra information during their procedure? I mean, it's invaluable. So let's talk about the technology. It's the world's only technology providing a real-time, three-dimensional representation of the shape and position of the endoscope inside the body. ScopeGuide is designed to improve procedural efficiency and increase patient comfort during the colonoscopy. It improves procedural awareness. That's an important term, procedural awareness. At any point in time during your colonoscopy procedure, you know exactly where the tip of your scope is. You know the configuration of your colonoscope, the looping, the stretching of the colon. You can see almost where the pressure points are and why you're meeting resistance as you attempt to advance that scope. Again, invaluable. If I was performing a procedure and I was meeting some resistance in the sigmoid colon, here's a loop in the sigmoid, and that loop is termed an alpha loop. Again, this is done fluoroscopically, but you can see the image of the scope fluoroscopically that says this is an alpha loop. Well, look at the picture I get with the magnetic endoscopic imaging technology of ScopeGuide to the right. It's almost identical to your fluoroscopic image without the radiation. In this way, I can see that this is an alpha loop, and then that would help me, you'll see in future slides, how to mitigate that loop and reduce that loop much more efficiently if I know it's an alpha loop. How does ScopeGuide work? An exclusive Olympus technology, ScopeGuide's 3D visualization assists with scope insertion and earlier loop identification. Real-time visualization allows the endoscopist to see loop formations as they are occurring for quicker and more effective loop management without having to rely on guesswork. You know, probably here, I think I'm here. This is no guesswork with this. ScopeGuide can help optimize scope handling, which may shorten procedure times and minimize patient discomfort even during those difficult colonoscopies, which we've all had the experience with. The scope here, the colonoscope, has these built-in electromagnetic coils. The colonoscope contains these electromagnetic coils. They're embedded along its length. They generate magnetic pulses from the coils, and those pulses are detected by a sensor to generate a real-time, three-dimensional image depicting the position and shape of the colonoscope in the abdomen. Loop formation is identified, and appropriate measures can be taken, and just as important, if not more important, exact anatomic position and location of the scope is obtained, as you've seen on the previous slides. These are some of the images that you may see when you're utilizing ScopeGuide during your procedure. So the A picture here, this is more of a spiral loop or an end loop in the sigmoid colon. Again, when you're advancing the scope, if you don't have this image, you're going to feel resistance, but you won't know what type of loop is forming. I think all resistance pretty much feels the same. In this bottom right-hand picture, this is very important. This bottom right-hand picture shows ScopeGuide with the tip of the scope in the right lower quadrant. This is your typical picture of when you completed your procedure and you were in the cecum. The ScopeGuide gives you more of a question mark type of appearance, and I look for this question mark time and time again at the end of my procedure. It's part of my photo documentation. It's part of my picture when I take a picture of the cecum. This question mark of ScopeGuide also reveals that I hit the cecum as well. So this is a little pictorial of how the ScopeGuide works with the receiver dish and the sensor. The scope emits these low-power magnetic field detected by the receiver dish. The signal is picked up by that receiver dish. Data points are then used to calculate precise scope shape in the body. ScopeGuide generates a three-dimensional image on the monitor. So these data points are then generated into a three-dimensional image such as this, and now that's what you see on your monitor. Again, looking at this ScopeGuide image, once you're familiar with this and use this a few times, you would know that you are in the cecum. There's your question mark. That is a complete exam there. These are the items that make up ScopeGuide. This is your ScopeGuide processor, which sits on your endoscope cart. Here's your sensor, your receiver dish, that picks up the signal from the electromagnetic coils. You also have a hand coil that comes with it. A hand coil, and you'll see this in some upcoming slides, the hand coil allows your nurse or technician assisting you to apply direct pressure onto the patient's abdomen where you see your loops on ScopeGuide. So instead of marching around the abdomen and when you're looping and you're getting paradoxical movement and you're trying to reduce your loops, you know how it goes now. Your nurse tries the left lower quadrant. She may try the left upper quadrant. She tries that sequel push until you get the right spot. Well, using the hand coil, you can apply direct pressure exactly to where you need it, which would save time and be much more efficient in your procedure. This image on the right is called Position Detecting Probe. This allows for any of the older generation scopes, mainly the 180 series colonoscopes, to make them ScopeGuide compatible by passing this catheter through the biopsy channel, and that will then generate the electromagnetic pulses that will be picked up by the receiver dish. So that's also in addition if you have the older generation scopes. Putting all that technology together, here you see on the left that you have the electromagnetic coils are built in along the length of the dedicated colonoscope, and they generate a pulsed low-frequency magnetic field. This is your receiver dish, which sits on the opposite side of the patient, right, across from the patient's belly. This receiver dish sits here and picks up the pulses from the scope. The receiver dish then relays that data points to the ScopeGuide processor. The processor then sends it to the monitor, and then the monitor will show you the 3D real-time image of the colonoscope and the configuration. Taking the guesswork out of colonoscopy, again, as I started out, you know exactly where you're at all times. Real-time visualization allows the endoscopist to see loop formations as they are occurring for quicker and more effective loop management. The ability to optimize scope handling can shorten the procedure times and minimize patient discomfort even during difficult colonoscopies. Real-time visualization also allows the endoscopist to anatomically see exactly where the tip of the scope is at all times. So let me direct your attention to the image on the right. If you just look at the endoscopic picture, once again, you really don't know where you're at in that colon. But now look at your ScopeGuide image that's superimposed. Let me walk you through this. We're coming up the left colon, right where my cursor is. We're traversing the splenic flexure. We're going down the transverse. We're going up, and we did not hit the hepatic flexure yet. So I would say by looking at this image, this picture right here is just distal to the hepatic flexure by utilizing ScopeGuide technology. I know exactly where that is. Looking at some of the loop identifications, as we advance the scope through the sigmoid colon, we've all felt resistance, but we don't know what's causing that resistance. Is it an alpha loop? Is it a reverse alpha loop? Is it an end loop? So this is an alpha loop. You can see the distal end of the scope goes in front of the proximal end, and that is an alpha loop. That's important to know because in order to reduce that loop, you provide a clockwise torque and pull back, and that usually very quickly mitigates and takes that loop out, and then you obtain a better one-to-one motion with the scope and avoid paradoxical movement. A reverse alpha loop is very similar to an alpha loop. The only difference is that the distal end goes behind the proximal end. Again, you would never know that without visualizing it. Your resistance and the feel, the tactile feel of that scope as you advance it through the sigmoid colon is the same. But by knowing and visibly seeing that this is a reverse alpha loop, during that real-time image, you can then apply the proper technique, which is reverse clockwise. So it's a counterclockwise torque and pull back, and that's how you mitigate a reverse alpha loop. Again, it takes the guesswork out, and you can go right to the indicated procedure and technique of reverse counterclockwise or counterclockwise pullback, knowing what type of loop that you have. So the indications for ScopeGuide. I mean, if you ask me, it's used for every colonoscopy I perform. That's the indication. But going through the structured indications, the instrument has been designed to be used with Olympus endoscope systems for the detection and display of the shape of an endoscope once inserted into the patient. It is indicated for those patients who require colonoscopy and enteroscopy, except patients with a critical active implantable device such as a pacemaker or an AICD, an implantable cardioverter defibrillator. And also, it's contraindicated in pregnant women. At the distance of 60 centimeters from the ScopeGuide, the magnetic field strength is approximately 0. So there is no consequence whatsoever if the clinician is 1 meter away from the ScopeGuide. Comparatively, ScopeGuide generates less magnetic field strength than common household appliances such as a can opener. Targeted pressure, creating that procedural efficiency that we touched on earlier. This is the hand coil that comes with the system. Your technician, your assistant can apply pressure to the patient's abdomen in the precise location that you see on your ScopeGuide that's looping. So once you identify the loop, you can actually have this hand coil on the abdomen, which is also picked up by the sensor, and apply the exact pressure where needed to avoid that loop. The next few slides will show you what I'm talking about in real time. So this is a procedure that I'm performing, and here we are going up the sigmoid colon. Fortunately, there was no sigmoid loop. There was no alpha loop. There was no reverse alpha loop in this patient. There was no end loop. So I had a nice straight shot going up the sigmoid left colon, and here you see on ScopeGuide, we're going into the descending colon, and there's my endoscopic picture. Right here, you can see I'm traversing that splenic flexure, just entering the transverse colon, and that's what we see here on the right. I go down a little further into the transverse colon, going deeper in the transverse colon, and here I am. I'm taking a nice deep dip in that transverse colon. I'm starting to feel some resistance when I'm advancing that scope. And you can see here, this is an important picture. I want to stop and pause and go over this a little bit in more detail. I'm hitting a turn in the transverse colon. It's a very deep loop. I'm feeling some resistance, but let's switch gears a little bit and see where I'm at. Look at the tip of my scope. I think everybody would agree that I am now entering probably the proximal transverse colon, and I'm looking towards the hepatic flexure. So ScopeGuide-wise, I'm looking towards the hepatic flexure. Let me direct your attention to the endoscopic image here. I think we confirm that by endoscopically, there's your liver imprint in the distance, right, that purplish hue, the hep bar, and that correlates 100% with my ScopeGuide image. Here I'm looking up towards the hepatic flexure. Endoscopically, I'm right there looking at the hepatic flexure. 100% correlation. Again, information to me that is invaluable. So going back to the pressure, I did not like the pressure that I was feeling. It was being too much resistance. I didn't want to cause any type of laceration. This is the splenic flexure would start looping if I'm pushing too hard. And as you know, rarely we don't want to obtain any splenic lacerations with that. So what I did was, in the next slide, I pulled my scope back. You saw I reduced that deep transverse loop. I had my nurse apply that hand coil. You see by the marker coming in, she's putting her hand exactly where I want that pressure to be applied. So I can prevent my scope from going that deep, again, the transverse colon, and trying to deflect the scope up and over. So if you watch on these next series of slides, she's getting her hand in position with that hand coil. And once she gets it into the right position, then I'm going to advance my scope, and my scope, hopefully then the tip will be deflected up into the hepatic flexure and not go so deep into the transverse colon. And you can see here, that's what we did here. So look at this slide. My scope now, what position am I in now? Where is the tip of my scope right here? Well, you can see, let's walk through it. We're coming up the left colon. Here's the splenic flexure. Down the transverse colon, not nearly as deep as my original deep take of the transverse colon. We just passed over the hepatic flexure here, right? And the tip of my scope is now looking south, looking down the ascending colon into the cecum. If you look to the endoscopic image to the right, here we are looking down the ascending colon. Here's your ileocecal valve and the base of the cecum. Once again, 100% correlation with your ScopeGuide image. Always available. I'll advance the scope a little further, and then I eventually get into the cecum, and here's your base of the cecum, here's your ileocecal valve, and again, I'll direct your attention back to the ScopeGuide image and looking at that question mark appearance, which also signifies that I've hit the end of the mark. Okay, very, very critical to my procedure. Again, I'm looking at my endoscopic image, and I'm also looking at ScopeGuide, and to me, I think having both of them available is just something that every endoscopist, I think, should be utilizing. Advancing control. This is a diagram here showing that the nurse having her hand, it's a picture, but having the hand coil applying direct pressure to a loop that's forming here in the colon. So what do we mean by advancing control? With ScopeGuide, we have more control of the situation. We have more situational awareness, procedural awareness. We can, hopefully with ScopeGuide, allow for faster insertion times. By that, we mitigate these loops sooner in real time. We're not floundering, trying different techniques. We know what's happening real time, and we can prevent these things from happening as we progress with our scope. So faster insertion times, allowing for improved patient comfort, less looping, less stretch, less sedation needed for the patient. Patient comfort is increased. Faster learning for trainees. I remember when I was a fellow, if I can visualize the loop, it would make much more sense to me. So teaching endoscopy, trainees that can visualize this in real time can mitigate these loops much more efficiently, and I think it allows for quicker learning, quicker training, and I think just a better experience for everybody in that room, not just the trainee, but the attending who's also helping to train the fellow. Higher success with difficult anatomy, need for less sedation, as we stated earlier, and I cannot stress enough, more accurate location for pathology specimens. Knowing exactly where you're biopsying from anatomically is huge for the patient, myself, and also if the patient needs surgery. I can tell the surgeon exactly where it was. We can all tattoo and place a clip, but there are cases where, sometimes you may think you're in the descending colon, and you could be in the proximal transverse colon. So if you tell your surgeon, I saw a mass, it's in the descending colon, and I tattooed it, if the surgeon thinks it's on the left side, that may affect the surgeon's incision. And I know this because my surgeon has said to me with other endoscopists that they made their incision thinking it's on one side of the abdomen, and in fact, when they got in, they did see the tattoo, but it was on the opposite side of the colon. So with ScopeGuide, that takes that error out of the picture. Several studies were done looking at ScopeGuide and improving efficiency in training. So this study showed random times over a 6-week period. Trainees, the fellows, participated in an individualized half-day session using ScopeGuide in a training model. Performance was measured during the 2-week period before and after the intervention. And the outcomes here are highlighted. The fellows or trainees increased the cecal intubation rate from 43% to 76%. Procedural times were reduced from 18 minutes plus or minus 11 minutes down to 14 minutes plus or minus 7 minutes. And there was less sedation and anesthesia used after the training model. Looking at established, experienced endoscopists, 122 patients undergoing routine colonoscopy by a single experienced endoscopist were randomized to have the procedure performed either with the endoscopist viewing the ScopeGuide image or without the ScopeGuide image. And the outcomes were as follows here. The average intubation time was reduced using the ScopeGuide imaging. The number of attempts at straightening the colonoscope once a loop had formed was significantly fewer, and the duration of looping was less when ScopeGuide image could be seen, which makes complete sense once you've seen these images. You can see how that makes a lot of sense. So again, the goal of our colonoscopy, what's our goal? When we insert the scope into the rectum, our goal is to get to the cecum efficiently with as straight a scope as possible to avoid paradoxical motion, getting that nice one-to-one motion that we all like to have. We push the scope, it's fast, it's quick, and that's an enjoyable colonoscopy with less risk to the patient. And here's your question mark diagram. You want to get that question mark appearance of the scope in a nice straight fashion with no loops. This is another pictorial showing an alpha loop, which we went over, and on the right, this is an end loop. We haven't seen that yet, but again, passing the scope through the sigmoid colon, it's stretching the sigmoid, you're creating an end loop, again, feeling resistance, but if you don't have your visual, you don't know whether it's an alpha loop or an end loop. All you do is feel resistance. Alpha loop reduction, once again, if you have an alpha loop that's shown to you by ScopeGuide, you can very easily mitigate that and reduce that by clockwise torque, pull back, and it reduces very quickly. Again, you would not know that without seeing it with ScopeGuide. I was fortunate enough to be involved with a large study supported by Olympus several years ago, and this study looked at efficiency case study results. It looked at one arm showed 190 series colonoscope, ScopeGuide, and CO2 insufflation, and the other arm with patients just used the 180 series colonoscope. And these were the measured outcomes: time to cecum, patients requiring abdominal pressure, patients requiring position changes, adenoma detection rate, mean adenomas per patient, and then patient time in recovery. And you can see the arm where we use ScopeGuide and the 190 series scopes versus 180 scopes. Look at the time to cecum, 4 minutes and 33 seconds versus over 5 minutes. Patients requiring abdominal pressure, 20 times versus 31 times without the ScopeGuide technology. Position changes, right? We all hate, and it's very cumbersome to roll the patient. We call it the rotisserie here. You roll the patient to the supine, you roll the patient to the right side. You know, look how many times that was reduced using ScopeGuide technology. It halved it. Adenoma detection rates, mean adenomas per patient were very similar, but patient time in recovery markedly diminished. Again, quicker times, less sedation, less propofol, less sedation used by the anesthesiologist, less time in recovery. ScopeGuide also made the news locally here in the Philadelphia area. Once they got wind of myself utilizing the ScopeGuide, I was one of the pioneers using it when it first came out 5-6 years ago. They came out, they interviewed us, and it was very successful. And I was able to show ScopeGuide to our community via our local news. In summary, in trainees, particularly first-year fellows, ScopeGuide improves cecal intubation time, reduces left-sided dwell time, reduces the duration of looping, patient discomfort, and attending hands-on. It prevents those attendings from grabbing that scope and taking it out of the fellow's hand because the fellow's dwelling too long and not progressing. By allowing ScopeGuide and attendings to, and seeing fellows to visualize this, fellows are more likely to complete the procedure on their own without the attendings grabbing the scope. ScopeGuide may also benefit the experienced endoscopist in similar fashion as above. Potentially, ScopeGuide accelerates the colonoscopy learning curve. I think by visualizing the loops, that's easy to understand. ScopeGuide teaches loop reduction techniques. Nurses and procedure technicians learn as well, and they can alter the abdominal pressure to be more effective quicker using that hand coil. ScopeGuide markedly increases specificity for pathologic specimens and colonic tip location. I cannot stress that enough. ScopeGuide increases participation of the procedure room attendees and helps engage all present in the room, including anesthesia personnel. So the anesthesiologist or the CRNA in the room can look at the monitor, they can see how close I am to the rectum, and they can then gauge and judge how much more sedation the patient needs. They can see when the end of the procedure is coming, rather than ask me, hey, doc, how much more sedation do you need? Or, doc, how much more time do you need? They can see the ScopeGuide image and then adjust their sedation accordingly. And lastly, for me personally, ScopeGuide adds another dimension to a very common procedure that we do every day. ScopeGuide enhances and improves my satisfaction and enjoyment for every procedure I perform with utilizing it. I mean, it brings, as you saw, another dimension to this colonoscopy procedure. And this is a true story. Just yesterday, I had to perform my last patient in a different endoscopy room for various reasons, and they could not get the ScopeGuide to work in my second room. There was a cable malfunction. So rather than cause much more delay and have the patient become unsatisfied, I said, let's just perform the colonoscopy without ScopeGuide. And I'll tell you, you know what it felt like to me? It felt like, do you ever leave your house without your watch? And you feel like you're missing something all day? That's exactly what it felt like to me yesterday with that last patient. I did not have ScopeGuide. I wasn't referring to it. All I saw was my endoscopic image, and I felt naked throughout the procedure without it. So once you adapt the ScopeGuide, you look for it every case. And again, do you need it? No. You can get to the cecum without it, but look at all the additional information you get by utilizing it and having it there in the background, seeing it all the time. So again, our goal is to get to the cecum very efficiently with that question mark. You want to see that question mark scope. This is what the question mark will look like on ScopeGuide. Look for that question mark. Look for the question mark, the end of your procedure. And to end the Riddler, as to his claim to fame is that question mark, look for the question mark. Thank you, and I'm available for any questions.
Thank you for that insightful presentation, Dr. Lichtenstein.
You're welcome.
We will now move into the question and answer portion of this afternoon's presentation. Audience, to ask a question, select the Q&A icon. The Q&A icon can be found in one of two places. In window view, the Q&A icon can be found on the upper right side of the WebEx screen. When in full screen view, pull down the WebEx toolbar from the top of your screen and select the Q&A icon. If you don't see the Q&A icon, click the drop-down arrow to find it. To submit a question, type it into the pop-up box. Leave the Ask spinner on all panelists. Audience, we do have a number of questions this evening. Should we not get your question, please contact your Olympus Endoscopic Area Manager. If you don't know who that is, contact us via our website, medical.olympusamerica.com. Our first question is, when and why did you first start using ScopeGuide?
Thank you for the question. I started using ScopeGuide 5 or 6 years ago. We opened up a brand new endoscopy suite inside our hospital, and we were obtaining all the new latest technology from Olympus. We purchased all the new 190 platform scopes, and when ScopeGuide was demoed to me at that time, I instantly saw, another dimension to the procedure. And I didn't realize at the time about the anatomic location that we just went through, but I saw the loop formation and I said, let's purchase it. I think this will be an added benefit. Why I used it, then I realized all the additional advantages that I initially never knew about. So I actually learned and grew with it, but I've used it since its inception.
Thank you. Our next question is about procedure time. Did utilizing ScopeGuide add any additional time to your procedures?
So thank you for the question again. Actually, the contrary. It's reduced my actual procedure time. Now, I will say in the beginning, to set it up and have the nurses and the techs and have everybody on board with the setup and making sure it's available for every procedure, that took a little getting used to just because the staff wasn't used to it. But I can tell you, going on 6 years now of using it, the staff, my nurses, they all look towards it now to utilizing it, and they actually question me why other physicians don't use it like I do, and it's hard for me to answer that question. But it engages everybody in the room, and now it improves the procedural efficiency. So, no, it reduces my scope time now.
Thank you for that. Our next question is, how long did it take you to become comfortable using ScopeGuide?
Thank you for that question. It's a good question. Actually, on day one, I mean, you're still performing your procedure, so we all know how to perform a colonoscopy. But just looking at it, there's not much of a learning curve. I mean, as you saw through those pictures, pretty easy to tell your anatomy. I mean, you know where that scope is. You know what the colon anatomy is. There was very little learning curve at all.
Thank you for that. And we have a question about what scopes does ScopeGuide work with?
So the ScopeGuide works with all the new 190 series scopes, including the adult and pediatric colonoscopes now. And as you saw in my presentation, if you do have the 180 scopes, they do not have the electromagnetic coils built into the shaft, but there is that probe that you can pass through into the biopsy channel to make it ScopeGuide compatible.
Thank you for that, Dr. Lichtenstein.
Sure.
So we have a question that's related to, I think you spoke of a surgeon asking, using this, and you talked about your staff asking why other physicians don't routinely use the ScopeGuide. Did you find that using ScopeGuide helped you market yourself?
Yes. So what I found was it's on our website, and I advertise that I do use ScopeGuide, and I've actually had several patients come to me. We utilize direct access endoscopy here at my hospital, and I'll often ask my patients, "How did you get to me?" And if I'm understanding the question properly, some of the patients have said, "Well, we saw your video on the website, and we noticed that you use ScopeGuide technology, and that's what directed them towards me, actually." So it is out there, and educating the patients that we have another modality to help improve the colonoscopy efficiency is, I think, beneficial, and the patients are understanding that it is helpful.
Thanks for that. The next question is about setup. You spoke a bit about the staff needing to be familiar with how to set the ScopeGuide equipment up. Do you feel like it added extra time to your turnaround?
No. So in the beginning, just setting it up and getting it in position for the procedure and getting the dish in the right position, again, maybe for the first few cases until everybody got familiar with it. But no, once it's set up in the room, no, there's no additional setup. Once you have your room turnaround, the stretcher gets wheeled out. The dish stays in the same position. You wheel the new stretcher in with the patient. The dish is already in position. And like I said, the electromagnetic coils are already inside the scope. So no, there is no additional, or there is no prolonging the room turnaround time once you have it set up in the beginning of the day.
Thank you for that. Our next one, in your opinion, is ScopeGuide more beneficial for determining anatomical location or identifying loops?
That's a great question. Thank you for that question. So I'll give a twofold answer. I think with the experienced endoscopist, I think anatomic location probably will win out on the identifying the loops, although, they're both very important and it helps improve efficiency by mitigating your loops. I think with fellows and trainees, probably the loop formation is more important to them and helping them advance the scope through those loops into the cecum. So I think they're both important. Trainees, probably the loop more so. I think with experienced endoscopists, there is no substitution whatsoever. I don't care if you've been doing this for 30 or 40 years. Having exact anatomic location is invaluable.
Thank you. We do have a number of questions. I just want to alert the attendees to please submit your questions now. We're coming up on almost time to say goodbye. Good night. The next question is, when do you not use ScopeGuide?
So thank you for that question. When I do not use it is like that rare occurrence yesterday for my last case where technically we had a cable problem. But I utilize it for every colonoscopy that I perform. In fact, if I have to go to the operating room to perform a procedure, everything gets wheeled down, including the dish and the processor. Everything comes down to the OR with me because I want ScopeGuide every time I do the procedure. So there is no time I can't use it unless it's a technical difficulty.
Great. Last question of the night. Would you argue that ScopeGuide is just as valuable for established GI physicians as it is for fellows?
100% yes. As you heard me state several times, and not to be a broken record, but sure. I mean, anytime you can identify the location of where you're biopsying from, 100% accuracy, again, how could you not want to know that? So for any experienced endoscopist, it's not so much getting to the cecum, it's knowing where you're at, procedural awareness. Remember that term, bringing in procedural awareness, and no matter how experienced you are, adding procedural awareness is something that we can all do better with.
Thank you, and thank you for a wonderful presentation.
You're welcome. Thank you.
Attendees, if you do have any questions, please don't hesitate to contact your Olympus sales representative. And if you don't know who that is, please feel free to visit the ScopeGuide page on our website and find out who can give you more information there. Lastly, thank you for attending our presentation, Improving Procedural Awareness Using ScopeGuide. Have a wonderful evening.